No.
Well, why not?
I need that time necklace.
The time turner.
Yeah, time turner.
Yep. Okie doke. So let's get this party started. All 4 or 5 of you, right? Anyways, I'm glad you all are here. All right, so we'll start with we're going to only do the midterm review for Pharm because that's what you guys need to know. Starting with chapter 1, the 5 phases of the nursing process. If you guys don't know the mnemonic or the 5 phases by now, you're in trouble. So, Mercedes, what are the 5 phases of the nursing process? And you can unmute. Probably went to go get something to eat. Courtney, what are the 5 phases of the nursing process?
Assessment, diagnosis, planning, implementation, evaluation.
Good job. Yes.
I was like, can I get a box?
You get a gold star. So, I mean, if you want to look at the guidelines about that, guys, it's on page 5, box 1-1. The very basic information. So, and kind of examples of what you're doing in each phase. You're fine, Mercedes. Didn't know I was going to be calling on you, huh? I know I'm being tricky. So that's in chapter 1. Know the 9 rights. So
I was in the wrong place. I'm sorry, guys.
that's okay. We actually just did the first one, which is the 5 rights, which is on like page 5. It's not. You think it'd be on page 2, but it's not. It's like So make sure you know your 10 rights. Which, okay. Hopefully you know your 10 rights by now. Chapter 2, make sure you know the difference between pharmacokinetics and pharmacodynamics. So, what is pharmacodynamics? Adriana.
The drug process?
Yeah. Yeah.
Like it's not, or it's like no, it's not absorption.
Yes.
It's absorption?
And it's the whole process.
Well, yeah, I meant that, but I thought, okay, that's like honestly, it's been a minute.
The body.
Yes, what the drug does to the body.
Perfect.
I know, I'm putting you guys on the spot now. How rude. And then, what is, let's see, can I just do pharmacokinetics? Yeah. What is pharmacokinetics?
What the body does to the drug?
Yes, very good. It's what the body does to the drug. So the pharmacokinetics is what your body does to the drug. The dynamics is what the drug does to your body. Okay. I know what that means in like applying drug therapy. So pharmacokinetics is actually starts on page 20. And pharmacodynamics is on page 28, or starts on page 28. And then I already said, like, know the routes of administration and nursing considerations, also called nursing implications. They're the same thing, guys. Starts on page 22, so it's the tables on page 22 and 23. And it's table 2-3, so you're looking at like the route and then the nursing considerations. You don't need to look at the advantages or disadvantages. So for IV, frequent monitoring to make sure you're getting the correct volume and amount administered, therapeutic blood levels, checking compatibilities, monitoring IV site, probably one of the most important things. Intermittent, making sure you're flushing the line. So those are the kinds of things that you want to look at. And I find rather than writing word for word what this says, so I didn't repeat word for word what was under the nursing considerations for IV, kind of put it in my own words. It's probably the best way to do it. Moving on to chapter 3. Pregnancy categories, they are on page 37. It is table 3-1. Category A, no risk. B, some risk. No risk in animal fetus, but there's not really human information. C, adverse effects reported in animal fetus, but we don't have human information. D, possible risk in humans reported. In select cases, the benefits outweigh the risk. And then category X, absolutely do not use. Stay away. Pharmacokinetic changes in the neonate and pediatric patient. That's on page 38. And that literally is, there's a box, that patient-centered care. So absorption, gastric pH is less acidic. Gastric emptying is slow, irregular peristalsis. First pass elimination is decreased because the liver's immature. IM absorption is fast, but it's also irregular. Distribution, the amount of body water, so 70 to 80% in full terms, 85 in premature, 64 in children's 1 to 12. Fat content lower because total body water is higher. Protein binding decreased. More drugs enter the brain because there isn't a very mature blood-brain barrier. Metabolism, levels of microsomal enzymes decreased. Older children might have increased metabolism, so they require high doses. Many variables affect metabolism, so liver enzyme production, genetics, and substances to which the mother was exposed. And then excretion, glomerular filtration rate and tubular secretion and reabsorption are decreased because of kidney immaturity, and perfusion is decreased. Decreased renal function. Just overall, it's not like not like, oh my God, it's a horrible thing, but that's just the way it is. So that affects the concentrating ability and the excretion of drugs. So basically, I want you guys, a big thing to know is absorption, distribution, and the excretion. A lot of this is due to immature organs. So liver and kidneys, most especially immature blood-brain barrier. So keep that in mind if you're coming across a question that has to do with infants and children. Age-related considerations for safety from infancy to adolescence. Again, this is page 39. So we've got that patient-centered lifespan, the CUSIN. Always come prepared. Ask the child if parent or child if the parent will remain, assess for comfort measures, appropriate comfort measures based on age. Infants, make sure that the infant stays in a safe position. Allow self-comforting, age appropriate, pacifier, fingers, all that stuff. Toddlers, offer brief, concrete explanation. They're not going to understand a whole lot. Accept aggressive behavior. They're going to do that, of course, within reasonable limits. I mean, if aggressive behavior, if the child goes to bite you, not okay. Provide, if they like are hitting it, you're like, no. I mean, that's one thing, but like if they're really gonna harm you, that's not good. Provide comfort measures immediately. Help them understand treatment and or their feelings. Use puppet play, stuffed animals, and provide healthy ways to release aggression. Preschoolers, again, brief, concrete explanation. Provide comfort measures after. Identify and accept aggressive responses within reason. Make use of magical thinking, like ointments or special medicines to make discomfort go away. And note the role of the parent in comforting. It's very important. School age, explain the procedure, allow them to have some control. You can allow them to choose which site you're going to inject them at or whatever. Make sure you provide comfort measures. Make sure you use therapeutic play, age-appropriate behavior limits, age-appropriate activity for releasing aggression. Teach about the relationship between receiving medication and bodily function. And make sure you offer the complete picture. Adolescents, prepare them in advance, but don't use scare tactics. Allow expression in a way that does not cause them to lose face, such as giving the adolescent time alone after the procedure. They don't even want to lose face in front of their parents, okay? So, and giving them time to discuss their feelings. Explore any current concepts of self, hospitalization, illness, and correct any misconceptions, because they're going to have their own ideas about what all this means. Encourage self-expression, individuality, and self-care, and encourage participation in procedures where appropriate. Physiologic changes in the older adult. Table 3-3 on page 41. Cardiovascular. So they have a decreased cardiac output. That leads to decreased absorption and distribution. Decreased blood flow, decreased cardiac output, also leads to decreased absorption and distribution. GI tract, increased pH. So they have more alkaline gastric secretions, equals altered absorption, decreased peristalsis, kind of sounds like kids, delayed gastric emptying, liver, decreased enzyme production, decreased metabolism of the medication, and decrease in liver and renal blood flow, decreases metabolism in the liver, and decreases excretion in the kidneys. Decreased renal function, decreased excretion. So anything that's decreased renal is going to decrease the excretion, okay? To put it easily. Medications and considerations requiring special considerations in the older adult patient. Page 43, I would specifically look at like opioids and like the sedatives, hypnotics. Those would be the important ones to look at, in my opinion. Hint, hint. Cultural implications for African, Asian, Hispanic, and Native American cultural groups. Page 51. Big pink box, another one. So African, they do folk medicine, root doctors, spiritualists, they use herbs and oils, and different, the family, close extended family. Biologically, the keloids, they have sickle cell anemia are common in African Americans. Asians, traditional medicine, the hot and cold. They really like the hot and cold. Acupuncture, herbalist, Herbalist is important because some of the herbs that they like to use are not good mixing with the meds. So kind of put that into a little box for yourself, go through all of them, and kind of have an idea. I would pay special attention to the, well, I mean, African because they're a large group, but Hispanic is also a large group. And so, but definitely know those. Know the importance and examples of HIPAA. So HIPAA is mentioned on page 53. And pretty much you guys should all know about HIPAA. Of course, what I lectured about today also kind of goes with this. Ethical terms relating to nursing practice, page 57. That blue, teamwork and collaboration, legal and ethical principles. All those terms, which we also, again, went through most of them in lecture today. Veracity is not one that we went over, and that's your duty to tell the truth. You have to be honest, okay, as much as possible. Sometimes you can't be honest, like with investigational studies, but the patient has already been informed when they sign the consent that they won't be told what they're on. And then elements of liability for nursing malpractice. We didn't really talk, specifically about these words. But some of the ideas, that's on page 58 in that little box, teamwork and collaboration, duty, breach of duty, causation, and damage. Chapter 5, how to prevent med errors. It's page 69. First step, assess information about drug allergies, vital signs, and labs. 2 identifiers, never give a medication that you have not prepared yourself. Minimize use of verbal and telephone orders and repeat the order to confirm. Speak slowly and clearly and spell the drug. List the reason for each drug on the medication administration record and any educational materials. So make sure you're aware of why you're giving it and the patient is aware. Try to avoid abbreviations because that leads to confusion. Never assume anything about any drug order or prescription, including route. If there is any question, you need to call the provider. Do not try to decipher illegible written orders. Call the doctor. Never use trailing zeros. Always use leading zeros. Carefully read labels for accuracy, expiration dates, dilution requirements, and any warnings, black box. Remain current with new techniques of administration and new equipment. Encourage use of the generic names to avoid medication errors due to many sound-alike, look-alike trade names, or what I like to, you can use salad or a lot of look-alike, or Lassa sound-alike, or salad is sound-alike, look-alike drugs. Listen to and honor any concerns expressed by the patient. Strive to maintain your own health, to remain alert, and don't be too busy to stop and learn. Become a member of professional nursing organizations. Know where to find the latest information on dosage forms. Safeguard any medications that a patient had on admission. Make sure the weight is always recorded. Provide mandatory recalculation for every dosage for high-risk drugs. Always suspect an error when an adult dose is dispensed for a pediatric patient. Seek translator when appropriate and educate patients to take an active role in medication error prevention. And then involve yourself politically in advocating for legislation that improves patient safety. That's chapter 5. Chapter 6. Know your different domains of learning. Those are all presented on page 75, the cognitive, affective, and psychomotor, and examples. So cognitive is knowledge-based. It's what you know. Affective is intangible. It's behavior. And then psychomotor is physical. It's the doing. It's the actual, it's an action. So cognitive is thinking, the brain. Affective is behavior. And then psychomotor is the physical action. Erickson's, page 76, box 6-3, infancy, toddlerhood, know all of those. The stages and what each stage is, trust, mistrust, autonomy versus shame and self-doubt, initiative versus guilt, industry versus inferiority. Educational strategies to address common changes related to aging. Page 79, table 6-1. So, like cognitive functions, slow down your pace, watch for verbal, nonverbal cues. New learning needs to relate what they already know. So, kind of need to know what your patient already knows. Decrease short-term memory, limit it to 1 to 2 objectives, small chunks. Decrease external stimuli, allow enough time, be patient. Hearing, speak distinctly and slowly and articulate. Sit on the patient's best ear, so if they hear out of one ear better than the other, sit on that side. Also, you might want to face the patient so they can read your lips. You do not have to shout. You can use a normal voice, but use a lower pitch. They can't hear at the higher pitches, so bring it down to a lower pitched area. Visual acuity, make sure they have their glasses, large print, high contrast, touch. Again, allow time. Drug responses and, wait, where am I? No, sorry, wrong chapter. Safe practices for discharge teaching, page 81. Blue box at the bottom. Also, individualize, begin teaching upon admission, provide positive reinforcement, complete a calendar that includes names and drugs to be taken with dose and frequency, involve family members. So other safe practices, follow policy, don't assume your patient has received adequate teaching before you. Always begin with discharge teaching as soon as possible, minimize distractions, evaluate teaching of the patient, utilize resources, use teach back, very important, guys. Document learning strategies, document what you taught. Chapter 7, page 91, measuring over-the-counter liquids safely. It's that yellow box, safety and quality improvement. Use measuring device that comes with the over-the-counter liquid med, not a household. If your medication instructions say a teaspoon, use the teaspoon in the measuring cup that comes with the medication, not an actual teaspoon. If it doesn't come with a measuring device, ask your pharmacist to recommend one. If you're using over-the-counter medications for a child, know the child's weight, because a lot of medications are dosed by weight, not age. Wash the dosing device thoroughly after each dose and store the medication and the dose device together. So you're using the same device every time. Don't use the dosing cup or syringe for one medication for a different medication, because they may not be the same. Drug responses and cultural factors, same page. It's right above that box in the pink. Responses to over-the-counter supplements might be affected by beliefs. If a patient is Japanese, experiences nausea, vomiting, or bowel changes, these are often not mentioned. Herbal alternatives might be used more extensively in some cultures. And that talks about genetic factors. So make sure you review all of that. Okay, chapter 22. Oops. Mechanism of action, example, medication names, indications for all of the following. So do drug cards, guys. Drug cards. Bestest, friendest in the whole wide world. So, angiotensin converting enzyme inhibitors or ACE inhibitors. That starts on page 348. So mechanism of action, medication names, lisinopril, indications, why you would use it, adverse effects, and then nursing implications. Okay. There might not be specifically here listed nursing implications. It may be further in. One thing you want to look for hypotension. Trying to see if there's a specific page for the nursing implications. That's why I don't like, one thing I don't like about that book. Doesn't talk about that. Anyways. So ACE inhibitors on page 348. ARBs or angiotensin 2 receptor blockers are on page 350. Losartan. Oh, you might also want to know enalapril or captopril. And then vasodilators starts on page 351. Okay, so do drug cards for all of those. And think about what things you might need to be aware of, what, nursing considerations. Okay. And feel free to use your drug book for some of that too. Although the drug books are a little bit more detailed. And actually I found out that the Davis's drug guide book is actually supposed to no longer be part of our class, and they've removed it from the syllabus and everything. So Mosby's is the drug book you're supposed to be using, and everybody should be having access now. Just FYI. Chapter 28. Diuretics. Again, mechanism of action, examples of meds, indication, adverse effects, and nursing implications. Loop diuretics. Page 454. What's the most common loop diuretic? Anybody?
Lasix.
Lasix. So Lasix is called Lasix because, by the way, just in case, and this isn't going to be on the test, because it lasts 6 hours. Get it? Lasix. Anyways, there you go. So that is on loop diuretics on page 454. Osmotic diuretics are on page 455. Potassium sparing diuretics are on page 456. And you guys are going, but that's yep, pretty much all of them. And then the thiazide and thiazide-like is on page 458. So again, mechanism of action, indications, medication names, some of them are common, adverse effects, and nursing implications. So adverse effects, guys, we're just looking at things. Major adverse effects, okay. Decreased potassium, elevated calcium, lipids, glucose, and uric acid, GI disturbance, skin rash, photosensitivity, thrombocytopenia, so you just need to list those, and the more common ones, list those first. So for thiazide-like diuretics, it says table 28-5. Those are the most common potential adverse effects. Or, sorry, 28-6. No, that's common drug interactions. 28-5, correct. Those are going to be your most common. So I would look at those. Chapter 32. God, it seems like it's been a while since we did diabetes. Oof. Difference between type 1 and type 2. What's the difference? Can someone tell me?
So, like, you mean,
One needs
Insulin.
insulin and one doesn't?
yeah, one dependent and one doesn't make it?
Correct.
Like,
Correct. That's the easiest way to say it, guys. You're in type 1, they have to have exogenous insulin. They're not producing any endogenous insulin. Type 2, they don't necessarily have that. I would say looking on page 502 at table 32-2 gives you a pretty good characteristics of type 1 and 2 where you can kind of tell the differences. So then page 501, major long-term consequences. It truly is table 32-1. So macrovascular and microvascular. Macrovascular, remember, is going to be the larger blood vessels, and the microvascular are going to be the smaller blood vessels, okay? So we're talking about like the coronary arteries, cerebral arteries, and some of the peripheral vessels, whereas microvascular is more capillary, okay? Signs and symptoms of hyper and hypoglycemia. Should be somewhere. So rather than scrolling through the whole book, I'm just going to do this. Look it up. Hypo. 500. Let's see. Ah. So hypoglycemia, you want to look at page 514. Symptoms include confusion, irritability, tremor, and sweating. And that's for hypoglycemia. Hyperglycemia is kind of mentioned on page 501. You actually would want to look at some of the symptoms of the symptoms, if you look at box 32-1 on page 501, criteria for diagnoses. Classic symptoms of hyperglycemia include polyuria, polydipsia, and unexplained weight loss. So increased thirst, increased urination, and weight loss. Okay. So those are going to be your signs and symptoms of diabetes, are going to be your signs and symptoms of hyperglycemia, because that's what's happening when you're finally getting diagnosed with diabetes. Let's see, we did the major long-term consequences. This is it. Onset of action, nursing implications, drug cards for insulins. So we are looking at the rapid acting, short acting, intermediate, and long acting. Now the book just does insulins, and that's on page 504, and it talks about the mechanism of action, indications, adverse effects. And then if you wanted to look at more specifically, if you look at the drug profiles on page 50, starting on page 506, it specifically says drug profiles, and it's got the rapid, short, intermediate, and long-acting insulins. So remember, rapid-acting insulin is the only insulin that can be given IV. And long-acting insulin should never be mixed with anything else. Then also drug cards for biguanides, which is page 508. And then sulfonylureas is on page 509. The reason why, guys, is insulins, the biguanides, and the sulfonylureas are going to be your most commonly given diabetic medication that you're going to see. Biguanides, metformin, it's the only one in its category. Glucophage is another name for it, but metformin, very important to know. Also know that if someone is going to have a contrast injection for any kind of test, they have to hold their metformin before and after. So.
I'm sorry, can you say that last part one more time?
Sure. If a patient is going for any kind of test that requires them to have like contrast, especially like IV contrast, they have to hold their metformin, so they can't take it. I can't remember. It's like 48 hours before, 72 after, or vice versa. I don't remember specifically. I don't remember specifically, and I don't think the book actually says. But because of kidney issues. So, yeah. Very important to know. Okay, chapter 38. I almost literally turned to it, guys. Differences between community-acquired infections and healthcare-associated infections. Pretty sure you guys got that. Community-acquired or community-associated, they acquired it in the community. If it's healthcare-associated, they got it while in the hospital. That simple. If I have to give you page numbers, you're complicating it. However, if you really want to know, it's on page 601, but that's the basics. Know the difference between antiseptics and disinfectants. Let me see. Where is it? That's also on page 601. So the disinfectant kills, the antiseptic inhibits growth, but it doesn't actually kill. So disinfectant kills, antiseptic inhibits growth. Page 601. Mechanism of actions, drug cards. I know, drug cards. You guys really, drug cards are going to be your BFFs, okay? Totally BFFs. So sulfonamides is on page 604. Penicillins is on page 606. Cephalosporins, hello, page 609, which actually the mechanism of action doesn't start. Where is it? That's weird. Oh, because it talks about the different generations. Yeah. So cephalosporin starts on page 609. There's quite a bit. Macrolides starts on page 613. And then tetracyclines, which actually, guys, go to page 616. That's where the mechanism of action starts for the tetracyclines. Chapter 39. Kind of doing the same thing here because it's part 2 of the antibiotics. Aminoglycosides, that information starts on page 626. Quinolones on page 628. And then the miscellaneous starts on page 630. There's clindamycin. So we want clindamycin, metronidazole, and vancomycin. Those are the ones that you actually have to look at. And they're in the little blue boxes. So Clinda is on page 630. Metronidazole is on 632. And then vancomycin is on page 633. Okay, I know we didn't get into the virus ones, but we're testing you on it, so that kind of stinks, and I'm sorry. Still responsible for knowing all the information. Differences between herpes simplex 1, 2, and herpes simplex 3. So here we go. Herpes simplex 1 is the most commonly associated with perioral blisters, and it's usually called oral herpes, so cold sores. Herpes 2 or HSV 2 is blisters on genitalia, so it's usually called genital herpes. HSV 3. Well, that's a new one. Oh, there we go. Human herpes virus 3 is the one, that's when we're talking about the varicella zoster virus. So right below, this is all on page 644, guys. So herpes virus 3 is chickenpox and shingles. It shouldn't be HSV 3, it should be HHV 3. So that HHV 3 is the varicella zoster. So that's varicella, chickenpox, and then also shingles. If you've had chickenpox, you're more likely to get shingles later in life. Difference between hepatitis B and hepatitis C. Hepatitis B is milder than hepatitis C. Hepatitis C can lead to liver failure. Hep B transmission occurs through blood and body fluid exposure. And this is all on page 645, guys. Yes, Christina, that is correct. Hep C is the leading cause of liver failure. Symptoms are usually mild but progress to chronic disease. Hep C occurs primarily from contact with infected blood, but can also happen through sexual contact. So your hepatitis, guys, that's on page 645. Hepatitis B is usually more acute. Hep C is usually a little more chronic. Examples of antiviral drugs. Table 40-1. So acyclovir and valacyclovir commonly used with the herpes viruses. Trifluridine. I don't think that one's going to be brought up much. Cimipravir, sofosbuvir, the hepatitis, influenza, immanidine, and romanidine are the most common ones you're going to see. And then some of the miscellaneous ones. But just be aware of those non-HIV antiviral drugs in that box. Epidemiology of HIV infections, box 40-2, page 649. Talks about viral factors. Virus easily inactivated, must be transmitted in body fluids. Long incubation period. Virus can be shed before you have symptoms. Sound familiar? Coronavirus, maybe? COVID-19? We're actually not sure how long people shed that. Transmission, I think you guys hopefully know how HIV gets transmitted. Groups who are at risk, probably pretty easy. Geographic factors, and then modes of control. Antiviral drugs limit progression. There's vaccines in trial, monogamous sex, using sterile needles, and screening programs for blood transfusions. And then highly active antiretroviral therapy or treatment. It's called HART. Oh, where is that? Even I don't remember all the pages, guys. I 650, 651. Awesome. 650, 651. Yep, there it is. Actually, mostly looks like 651. There on the left-hand side, highly active antiretroviral therapy refers to combinations of antiretroviral drugs or cocktails that are now standard for treating HIV-infected patients. The combination therapy is normally begun immediately upon confirmation. Opportunistic infections are treated with infection-specific antimicrobials. Prophylactic treatment for opportunistic infections is common. So that's what you need to know about HAART. Retroviral drugs, the adverse effects and nursing implications. That's on page, excuse me, 652. Okay. And on the retroviral drugs, you just need to know the adverse effects and then the nursing implications. So, and then it actually has there, common adverse effects of selected antiretrovirals are listed on table 40-2, so if you wanted to look at that, but you just need to know some basics. Chapter 53, vitamins. Fat soluble, water soluble. Honestly, guys, those first two ones can be answered on page 841 in that table 53-1. Fat soluble are A, D, E, and K. Water soluble are the B vitamins and vitamin C. So if they're water soluble, are they stored in the body?
No.
No. Correct. Fat soluble ones are, so you can develop toxicity. Food sources for vitamins A, D, E, and K. Vitamin A, food sources. Oh, hey, look. Actually, page 843, table 53-2. It lists actually all of them, but you just need to know the first four, A, D, E, and K. So A, liver, fish, dairy, eggs. D, dairy, fortified cereals, fortified juices. E, and then K. Okay. It's literally there, again, page 843, table 53-2. Let me find magnesium. Now we gotta go further in here. I'm too far. So, mechanism of action, indications, and adverse effects for calcium starts on page 853. Okay. And then magnesium starts on page 855. Magnesium, guys, is a smooth muscle relaxer. So you know that it works like that. So, you might end up with, I don't know, diarrhea, GI issues. Of course, it goes into the tendon reflux loss, difficult bowel movements. There you go. Central nervous system depression. Anyways, sorry. Totally, but magnesium, that's why it's used for constipation. So that's there. Chapter 55. Make sure you know your difference between enteral and parenteral. Enteral is anything that goes through the GI tract. Parenteral is anything that goes through the veins. You can actually see they define them on page 872. The differences between peripheral and central total parenteral nutrition. That is discussed on, well, peripheral starts on page 875, and since you just need to know the difference, actually, there's a table, page 875, table 55-2. It compares and contrasts the characteristics of each. And then know your nursing implications, so considerations. So what things would you look for someone on that? So I would look at the implementation section that starts on page 879. Checking feeding tube placement, looking at gastric residuals. Diarrhea is a common side effect of these So all right, I want to look at something real quick for you guys. Okay. So Hep B, mild, transmission, blood and body fluids, can be transmitted to infants. Hepatitis B has a vaccine. The antiviral therapy for hepatitis B is lamivudine, tenofovir, and telbivudine, and alpha interferon. And guys, these are on the slides for the antivirals. This is on the hepatitis B is on slide number 19. And then hepatitis C is on slide 20.
You said that was for the antidote?
No, this is for hepatitis in the antivirals.
Oh.
So this would be chapter 40. Yeah, so let's see. Examples of antiviral drugs, definitely no amantadine, rimantadine, aciclovir, ganciclovir. So basically on your slides, starts on slide 23 and goes through excuse me, a lot of the slides. Slide 31. So what did I say, 24 to 31? No. 23. So slide 23 through slide 31 goes over the antivirals that you just need to know. So the examples of the non-HIV antiviral drugs, those are the slides they're on, in addition to using the table to kind of help focus, because there's more on the table. Okay. Opportunistic infections. Okay. Looking, because I want to try and make sure, I know I didn't get through these slides, so I want to make sure you look at which slides make sure you're looking at the right slides and can go through those. I don't really discuss heart therapy in the slides, which kind of sucks. sucks. Talks about antiretroviral. So I will give you guys a clue with the implications because they're not directly in the book. But if you go through the PowerPoint slides, and if you have any issues, send me a message if you can't access them. That the implications are usually listed right afterwards. So, for instance, in these slides for chapter 40, the nursing implications start on the slide 46. A lot of it is stuff you're already going to do. Before beginning therapy, assess underlying disease, medical history, and allergies. Assess baseline vital signs and nutritional status. Look for any contraindications. Duh. Proper application technique for anything that's like an ointment or powders. Hand washing. Wear gloves or cover their fingers when applying ointments. But these are all start in the antiviral section. These are all implications. So the rest of it you can get in the book, but the implications aren't clearly defined. Use your slides, guys. Math review. Again, go back over your homework, especially ones that you might have missed. Look at chapters 1, 2, 3, 4, 5, 6, 7, 11, and 13. If you have any issues with those, feel free to let me know. I'll be available. If I don't answer, it's because I'm in the middle of doing something else, but I will get back to you. Best way to reach me is through chat and Teams. It's like sending me a text message as opposed to sending me an email. So practice, I would recommend doing the rapid practice problems in each of the chapters, the end of chapter math problems. And if you run into anything, let me know. Nobody is doing really horribly at math that I'm that concerned. I think you all just need to take your time and read and set up the question. So, any questions, guys? And I'm available later this afternoon. I do have a meeting that usually lasts from 3 to 4. But I'm available if you have any math issues. I'm available all day tomorrow if you have any math issues or any questions or concerns. And I'm available Monday morning if you need some last minute stuff. Although I do have some scheduled meetings, but with some students, but I can find time. So.
For the slides on chapter 40, on slides 46, that's for the heart, H-A-H-A-A-R-T, correct?
It's actually kind of it actually kind of goes for all of the nursing implications for the entire antivirals.
Okay.
I know, sounds really weird, but they're all pretty much similar. So. But yeah, the slides, definitely when it comes to implications, the book doesn't do a good job of delineating them. So go back to your PowerPoint slides for each chapter. That's my recommendation.
Okay, thank you.
You're welcome. All right, guys, is there anything else?
So I have a question on the drug cards for the meds.
Yes.
You would prefer that we know the generic, right? Or whatever's in the...
Yes. The generic is the best name to know, guys, because there's going to be a lot less confusion. A lot of the brand names, trade names, there's too many look-alike, sound-alikes.
Okay. I just don't want to study if it's going to be worded differently in the exam.
No, I get it. Use generics.
Okay.
So for some of these questions, are they going to be sort of the ones that we've already kind of went over or tested over already?
They're going to be very similar.
Okay. Thanks.
You're welcome.
Okay, so for example, like the antihypertensive,
Mm-hmm.
like enalapril, nebivolol, the LOLs,
The alols.
alols. Okay. I
No, those are beta
struggle with-
blockers. So
Oh,
yeah, you want the ACE inhibitors, the ARBs, and the vasodilators. So the ACE inhibitors are all going to end with pril. So enalapril, lisinopril, captopril. And then the ARBs are the angiotensin receptor blockers, or ARTANs, ARTAN. So losartan, candesartan, telmisartan, those are going to be those.
is it ARTIN?
AN, ARTAN.
Okay. Okay. I just
Yep.
want to make sure I had an example so I don't have to bother you.
Not a problem.
Thank you.
You're welcome. Anyone else have any questions? You're very welcome. All right, guys. So if you don't have any questions, we'll go ahead and I'll see you guys. Wow, have a great weekend, I guess I should say. And I'll see you all on Monday. But again, don't